Okay, we'll get started. Thank you to everybody for joining us today. And thank you to Juliya for inviting me to do this with her. Juliya is an attorney, I'm a physician, and together we're going to talk about healthcare proxies, advanced directives, living wills. So you're going to have a lawyer and a physician weighing in. Juliya Ismailov is a trust and estates attorney. She's licensed in New York and New Jersey. I am Dr. Gerda Maissel. I'm a physician and an administrator who is no longer doing that. And I'm now working as a healthcare advocate in a business I started called MyMD Advisor. And as a healthcare advocate, I help people with complex issues navigate the health system. First, I'm turning over to Juliya. You'll see her slide set. And then with any luck, when she's done, I'll be able to put my slide set up for you and you'll hear the physician perspective. We will take questions at the end, although you are more than welcome to put them in the chat box. Both my presentation and Juliya's are each about 20 minutes long. That'll give us plenty of time for exploring any topics that you all might be interested in. And with that said, thank you again. And Juliya, please take it away.
Sure. Thank you, Dr. Maissel, for all your hard work as well in preparing this. I've just admired Dr. Maisel's very thorough process in making sure we cover everything. So, okay, so this is our presentation on this topic that first I'll discuss, the document itself goes by many names. So I'll touch on that in my definition section. And then I'll talk about some of the history behind the laws in place to basically protect a person's rights to express their wishes as to their healthcare, including end-of-life decisions. I will discuss some of the provisions that go into this document, including naming a healthcare representative or proxy or surrogate, the expressions of wishes, the expression of wishes section, the HIPAA release, and then end-of-life decisions regarding life support, artificial nutrition, organ donation, and religious considerations that can come into play. Okay, so on the definitions front, this document you all may have heard referred to by many names: Healthcare Proxy, Healthcare Directive, Advanced Directive, Living Will. You may even have heard of it referred to as a power of attorney. And so first I'll just address the correct names, which are the Healthcare Proxy. Could be the proxy is the person serving in your stead if you were no longer competent to make healthcare decisions for you. And then the whole document is often referred to as the healthcare proxy. Advanced directive is the portion where you're actually expressing your wishes in advance and making directives to the extent you'd like to express wishes. Living will is the same thing, a document that during your life you're expressing your will as to your healthcare decisions, as opposed to last will and testament where you're expressing your wishes with respect to your assets upon your death. Okay, and a power of attorney is a different document that gives someone the right to make financial decisions on your behalf. And it does not cover medical decisions, and healthcare proxy does not cover financial decisions. So those documents do need to work together. The people you appoint under the two, they could be the same or different people, but you do have to realize that there are situations where someone in making a medical decision is also signing some kind of a waiver of financial responsibility or signing on to financial responsibility. So that will need to be a different person, whoever you named in the power of attorney. And so it's sort of a broader estate plan where you have to consider who you're naming. And then the MOLST form is, it's a medical orders form. It's an actual order pre-signed by a physician that Dr. Maissel will explain. And it overlaps with the legal document, but does not replace it. The history of the healthcare directive laws is that at a certain point about, in the 60s, more people ended up at the end of life in an institutional setting, in a hospital, in an ICU, a rehabilitation center, nursing home, as opposed to 50% of people dying at home before in prior generations. So now there were multiple actors, decision makers, interest in the conversation of especially end-of-life decisions, like should someone stay be put and stay on life support, and whose decision is it ultimately. So that's what brought about movements to pass laws allowing someone to make an advance directive and name a representative who will make those decisions. They will be one voice or maybe two people making that decision that will override any other decision makers, regardless of what other family members may think, what the hospital may think, what's in their interest. This made it much less contentious at the end, and was supposed to relieve a lot of emotional and financial, all kinds of complexities at the end. So actually, an example of that is the Cruzan case that was decided in the early 90s. It went up all the way to the Supreme Court, United States Supreme Court, from Missouri, where a woman, she was 25, was in a car accident, and she ended up in a coma irreversibly, and something called the persistent vegetative state for many years, about 5 years, before her parents had to file a lawsuit to remove artificial nutrition. In this case, was the form of life support. And it was a long fight, and there were some constitutional issues involved, and some factual issues as to whether she had expressed a wish regarding end of life. And ultimately, her parents did succeed in the Supreme Court recognized the right of someone, a fundamental right of someone to decide to withdraw, have life support withdrawn, as long as they expressed that wish when they were competent. And the parents did accomplish this. But can you imagine what they had to go through, the ordeal? And in fact, I read, and this was shocking to me, the father, 6 years after they won and they pulled life support, committed suicide. And in his suicide note did mention his daughter. So to avoid, I mean, this is an extreme case, but to avoid the heartache for the family, some people find it to be the responsible thing to just have these discussions, regardless of how hard they are, with family. And the Patient Self-Determination Act of 91 came on the coattails of this case that caused, basically, the federal government can incentivize hospitals to whom they pay Medicaid and Medicare dollars to ask for an advance directive to be put on file, and if there isn't one, to offer a document from the hospital. If the person's competent, they can still have the opportunity to put it in place. Okay, so the different aspects of the actual documents. The first and foremost is the designation of the healthcare representative, sometimes referred to as an agent, a proxy, a surrogate. That's the most important thing, because even if you think of different scenarios, you're not going to be able to think of everything, and someone will need to make those decisions in the gray area. Someone will have to be the signed consent forms. Dr. Maissel will discuss that further, but that's an important person, and someone you should trust, that they will be able to carry out your wishes, even if they don't agree with them. And just so everyone knows, in lieu of someone that you have designated, if someone didn't have the chance to, then the family can make decisions under the default law in New York. It's called the New York Surrogate Act. For someone can act as a surrogate. So there's a family tree of the spouse and then the kids, but when it gets to the kids might not agree. And further family members, there might be a conflict. So you don't want to rely on the default law. And then once you designate someone, it is up to you whether you say all decisions are in the discretion of my healthcare representative, and they know my wishes and I would like them to act consistently with them. Or you can state those wishes and give more color. And specifically at the end of life, that's the next slide, you can make those judgment calls yourself in advance. And then the HIPAA release kind of goes hand in hand with that decision-making process, because HIPAA protects your medical information, but if your surrogate or representative doesn't have access to it, they're not going to be able to make informed decisions. So that's something I build into my document. It could be a separate HIPAA release document, but you don't want to have too many documents floating around, so I put them together. So that's basically the three components of the healthcare proxy document. So the end of life decisions are, there are a couple of buckets that you could break out the decision making. So you can request a life-sustaining treatment, which can include a ventilator, other forms of life support, artificial nutrition. Dr. Maissel will discuss that in more detail. You can choose to discontinue that in 3 scenarios. You can have more scenarios, but the ones in my document and ones I've seen in other documents are a terminal, incurable, or irreversible condition. So a terminal being defined as having less than 6 months to live. So you would prefer not to artificially prolong life in that case. Non-terminal but degenerative, where the burdens of treatment will eventually outweigh the benefits. And persistent vegetative state, it goes by other names also, but in those 3 scenarios, you would say, I would like to discontinue or not start life-sustaining treatment. Or you could say, I would like to prolong life as long as possible. And that is a choice someone has, even if the family doesn't agree. And if the hospital thinks it's not cost efficient or they think it's futile, you can make that decision, and you can, you may feel like in your best interest is that you're there in some capacity. It's very tough thought process to go through, but these are basically the meat of the end of life decision is these 2. You choose to prolong life through life-sustaining treatment or not. And that artificial nutrition is a separate component. So if you choose to discontinue life support, well, does that include artificial nutrition? You can still continue getting that. Some people may feel, I don't want to starve. Pain relief, those are choices. That's not just an end of life decision. Some people have more, have certain values associated with using pain relief. I know that's the case, for example, when people are making a birth plan. I think of that as a little bit of a corollary. This is sort of an end of life plan. A birth plan is a type of advanced directive as well, for example, epidurals, and I would like to not get a C-section if at all possible, those kinds of things. DNR is a subset, also a type of advanced directive, very specific, and that is part of the medical orders form that Dr. Maissel will discuss, CPR as well. So these are subsets of an advanced directive that can be put in a legal document, or it could be put in the medical orders document that Dr. Maissel will discuss. And then organ donation, and that plays into, you could say, I would like life support withheld. However, if it's required to preserve organs before they are harvested, then prolong life just for that purpose. Example, I thought this was useful. There are resources out there of the kinds of discussions one may have with yourself and with your family members. So this one's very broad, but which of the following do you fear most near the end of life? Being in pain, losing the ability to think, or being a financial burden on loved ones? So people feel differently about these questions. No one feels the same, and there's no right answer. But based on those values is how you would guide your family when someday they have to make decisions for you. And then here's an example. If you had Alzheimer's and it had progressed to the point where you could not recognize or communicate with your loved ones, which I had, my grandmother was in the state for about 5 years. And in addition, it says, and spoon feeding was no longer possible. Would you want to be fed by a tube in your stomach? So we didn't have to actually address that issue, but when she did get pneumonia, ultimately we did not put her on life support, and it was tough. But that's, everyone knows someone, so it's just thinking it through for yourself, which is not easy. Okay, and then religious considerations. People do put in their healthcare directive that they would like certain religious figures in their life consulted. They may express, in some detail what their religious views are. that, for example, for some people involves like blood transfusion decisions. So that's where you would put it in the healthcare documents. And then disposition of remains, I just want to point out, does not go in the healthcare document. It seems like it would make sense, but it can, but it wouldn't be binding here because the healthcare directive just governs during someone's life. But it could go in there as a type of, to provide guidance, but it should also go in a separate document or in your last will is where I put it, those instructions. So again, I just want to emphasize that this is all food for thought for someone to make decisions, have conversations with family. It could take years, this conversation. This is just a subset, by the way, of estate planning in general, where someone creates a last will, a power of attorney. This is another piece of it. It's the most sensitive part. And it's not a one-time, like check the boxes and be done with it. You have to go back and talk to the person you name and constantly be thinking, what is your position? Okay, so this is the end of my piece. And I will turn it over to Dr. Maissel. She will pull up her presentation. And again, jot down any questions you have or comments from your experience. I'm going to start sharing here. Okay.
Yep, let me unmute. Thank you, Julia. That was terrific, very clear. And I think gave us a really good grounding on the whole legal standard and what goes into these advanced directive documents. Okay, just to double check, can everybody see my slide that says advanced directives? Is that up? A couple standing there? Julia, I'm looking at you, it's up. You're muted.
Yes,
okay.
yes. I saw a few thumbs up.
Wonderful. Okay, well, thank you, everybody. And as a reminder, jot down your questions for Julia or myself. You can put them in the chat or just hold on to them, and we'll go over them at the end. So, all right, let's get started on the medical point of view on advanced directives and end-of-life planning. So first of all, let me tell you the sections about what I'm going to talk about today. That form that Julia talked about, a form called the MOLST, but it is actually very useful for you to know about. Not everybody knows about the MOLST form, and you'll understand why it's an important complement to the advanced directives that are prepared by lawyers when I explain it. We're going to talk about how we in medicine use your advanced directives. Sometimes people wonder, well, if I write all this down, does it get used, and how? I'll go into some considerations for you to keep in mind if you are named a surrogate, and you might be a surrogate for a sibling, for a parent. You certainly will be a surrogate for your spouse unless there's a reason not to. And this will give you some ideas of important things to understand. And then we'll do a little section on end-of-life planning, since we're kind of on the topic. And I have my last slides on hospice, so that people can understand a bit more about this very misunderstood area within medicine. Okay, so this is the MOLST form. This on the right is page 1 of a 4 or 5 page New York document. The MOLST form, MOLST stands for Medical Orders of Life-Sustaining Treatment. MOLST forms go by many names in the country, and each state has their own form. The original version was called a POLST, not a poltergeist, but a POLST, for portable orders of life-sustaining treatment. And probably the third most common name is the MOST, for medical orders on scope of treatment. And I will explain the relationship in a minute between the MOLST and the advanced directives. But first, I want to give you a little context and a little background as to how the MOLST came into being. Well, as Julia mentioned, back in the 80s and then certainly into the 90s, there was a real sort of effort within the country for people to be able to say what they wanted for treatment. And the one that really was the focus was do not resuscitate. What was happening is that if somebody was in the hospital, a medical order could be written and said, do not resuscitate. Well, if you weren't in the hospital, let's say you were in your home and God forbid you went down, you had a sudden arrest. Even if your desire was to be do not resuscitate, you get resuscitated. And the reason you get resuscitated is the standard of care for emergency service workers is to attempt to save a life. And they are obligated to do everything possible. So this wasn't good. And I remember seeing patients who literally had DNR tattooed across their chest so that they wouldn't get resuscitated. And just by the way, the reasons that people don't want to get resuscitated vary from believing and wanting to just let a natural passing of life occur to knowing that not everybody does well when they come back. Sometimes after resuscitation, there can be an anoxic brain injury. Frequently, especially in elders, ribs are fractured. So people became more aware of this, and many did not want to be resuscitated. So there needed to be a way that the emergency medical responders and others in the community would know what someone's wishes were. And a healthcare proxy, the whole document, the living will, is a very important document, but it's in a drawer, or the ambulance has, the attorney has it. And when the ambulance comes, they don't know. So this concept was brought forward back in Oregon, actually in 1991. A group got together and they developed the POLST. And so it's portable orders for life-sustaining treatment. And we did something similar in Rochester, just calling it the MOLST, for medical orders of life-sustaining treatment. And so I keep repeating the acronym because I want you to really hear that what these are medical orders that you have with you. You fill out this form, you go to your doctor, you agree on what you want, the doctor has it on record, he or she signs it, and it can be in New York, actually, a PA, an NP, or an MD or DO can sign this. And so now there is an order, and that medical order says, do not resuscitate. And for the emergency medical services to know about it, you put this paper up on your fridge. My mom actually has it on the back of the door, but either way, it's someplace where emergency personnel are going to see it. So now you're down, you can't speak for yourself, and they have a medical order that covers them. They now know, okay, I have an order. I don't have to follow that standard of care and resuscitate someone who doesn't want it. So basically, what these medical orders do are they turn a person's treatment wishes into actionable medical orders right there out in the community in a non-hospital setting. And let's see, what else do I want to tell you about that? I think I've covered that. Oh, the only other thing to mention before we go to more details on the MOLST is that this is fundamentally designed for elders and others that are at risk for hospitalization. And I mentioned, I think, the bright pink paper that makes it easy to find, and the emergency medical service people look for it. I went backwards, my apologies. So let me just give you a little bit more detail about what's in a MOLST, because you wanted to know, right? So, and to give you some definitions too, which is DNR. So a resuscitation is what happens when somebody has no breathing and no pulse. We are resuscitating you. We are in essence trying to get your life back, your pulse back, and then you'll start breathing again. And so a resuscitation is the chest compressions. We could usually, but not always, breathing for you, and the electric paddles that if your heart's in a funky rhythm, we shock it to get it back into a normal rhythm. That's resuscitation. Now, since DNR became well known, and we started also talking about DNI. DNI, you know what that is? DNI is do not intubate. Now, an intubation is when we put a tube down your throat and then we breathe for you either with an ambu bag or a ventilator, mechanical ventilator. That's done when somebody is breathing and has a pulse. They're alive, but they may not be able to breathe enough to oxygenate their blood. And some people don't want to be intubated. And so if you are DNR and DNI, you're not resuscitated. And if you're found down with a weak pulse, they don't intubate you. On this MOLST form, by the way, there are other pieces of information. Sometimes a person is at the stage of their life where they don't want to go back to the hospital. And you can indicate on your MOLST, basically, I'm done. Maybe you're in a nursing home, maybe you're in your own house, but you can say no hospital transfer. And there are other things, like you see this lady here, she's hanging IV fluids, that intravenous fluids. That's commonly done if somebody might be dry or have been bleeding, and you can say, no IV fluids. I don't want that. So it just gives you some very specific things that can be used by emergency personnel to know what you might want. Interestingly, there's indications about feeding tubes as well on here, but it's in New York and it has a very detailed form. Now, in the hospital, it's not uncommon for us to be aware that people are what we call DNR, DNI, do not resuscitate, do not intubate. And sometimes that gets mistaken for we don't want anything done, but that is not correct. If you're DNR and DNI, it's only about that. You can still get oxygen, pain relief, antibiotics, whatever else you might want. It only pertains to DNR and DNI itself. Okay, so let's talk about how MOLST complements the advanced directive but doesn't replace it. Okay, both together help ensure that treatment wishes are honored. Just need to move this out of the way so I can read it. The advanced directive does not have medical orders. It's a document that gives releases, that designates a surrogate, but doesn't have medical orders that are actionable in the field. A MOLST talks about your preferences, but does not name a surrogate, and it has those medical orders in them that are actionable. Hopefully that is understandable. Okay, and I am now trying to find my screen advance, which has disappeared. Let's see. There we go. Okay, so next, let's talk a little bit about how we make medical use of your advanced directives. Well, the first thing is, and Julia talked about putting in a HIPAA release. As medical professionals, we are obligated to not give your information to anyone. We protect your privacy unless we know that it's okay to talk to someone about it. Now, if you're alert and awake, of course, you'll tell us who we can talk to, who we can share information about you with. But if you're not alert and awake, if you've signed a HIPAA release, then we can talk to the appropriate people, family or whoever it is that you would have wanted us to talk to. And then the HIPAA release also comes up when it comes to release of records. I can't just walk into a hospital where Julia was and say, oh, I'd like to see Julia's records from her birth. Yeah, no, they would not give that to me. I could say, I'm a doctor, I want to see Julia's birth records. No, I can't. It doesn't work that way. It's only if Julia said, oh yeah, this lady here, she can look at my medical records. It has to be specifically released. Okay, treatment wishes. This is a big one for us in medicine because there's a lot we can do these days. We can treat you, and it doesn't just mean giving, putting you on a ventilator. There are, long lists of drugs and antibiotics and options that continue to improve all the time. And so we want to offer them to you medically. This is what we do. But we want to get an idea as to how far to go. What do you want us to do? What do you specifically not want us to do? Now, if you're awake and alert and you can comprehend and communicate, we of course are going to talk with you about your treatments, your surgeries, anything that would be related to you. And by the way, even if you wrote an advanced directive, I never want a tube in my stomach, when it comes down to it, if you can communicate it, you change your mind, you can change your mind. So we always will ask you to make the decisions unless you can't. And so when you can't, that's when we talk to your surrogates and we read your documents. And we take it very seriously because the days where it was very paternalistic culture, where doctor knows best, there are a few people around like that now, but frankly, much more now, there's just a focus in the culture within medicine on we want to do what makes sense for this individual that we don't know, but what makes sense for them in their life matters to us. So I'm going to switch a little bit here, and now let's talk about kind of the ins and outs if you're a surrogate. And as Julia mentioned also, even if someone doesn't have a document, it's going to go, you may end up as a surrogate for your spouse, for your parent, because it goes to next of kin. So it's good to have some preparation as to, if you're the surrogate, what would they have wanted? And I really want to stress here that the surrogate is supposed to express the person's wishes, the ill person's wishes. And sometimes they're not your wishes. So I'll give you an example, and this is a pretty typical conflict, and this is probably the most common one I've seen. Let's say you have, we'll just say 2 daughters. Daughter A has one opinion, daughter B may agree, but daughter B is the surrogate. Well, daughter A says, we can't starve mom. We can't, we've got to give her food. We'd be killing her if we don't give her a feeding tube. She's going to die, and it'd be our fault. We're starving her. And daughter B may think, I really want mom to have that feeding tube. I'm not ready to let mom go. I want her to have it. But if there's been a conversation and daughter B is the surrogate, and the surrogate knows that mom very clearly never wanted a feeding tube, daughter B is going to need to say, as much as I'd like to do this, mom didn't want a feeding tube and we can't do it. And so it's painful, and sometimes you get into conflicts with family members, but it's really respectful and a gift that you can give to your family to do what they would want you to do. You're not making a decision for what you want, you're making a decision for what your family member wants. And I'll tell you, the more you discuss it ahead of time, the more comfortable you'll be, because you'll just really be sure this is what your loved one wants. Now, I'll give you a story from my own life with my father. So my father, in his mid-80s, developed a neurodegenerative disease. And what that means is he was just slowly getting weaker, started losing the ability to use his hands, his walking got worse, his sitting got worse, and he was diagnosed, and it was clear that this was going to progress. Now, some people with these illnesses live for a number of years, and they get to the point they get feeding tubes, they go on ventilators, et cetera, and they're often in and out of the hospital. Well, my father, who was a PhD physicist, was a smart guy, and he looked into what his likely course would be, and he talked with me about it. And I said to him, well, one of the first things that's going to come up, Dad, is your swallowing is going to get worse, and they're going to want to thicken your liquids. And this is just something that I happen to know as a rehabilitation physician. I know what's coming down the line. And so I said, so, just be prepared. We're going to have to make your tea thick. It'll be more the consistency of honey. And every time we talked about it, Dad said, I don't want my liquids thickened. And I'm like, but Dad, you'll get a pneumonia. And then you'd have to be on antibiotics, or it might even kill you. And every time we talked about it, he said, pneumonia is an old man's friend. And what he meant by that was that pneumonia can be a convenient way to pass. For him, he wasn't willing to continue with this condition that was going to continue to get worse. He knew that there was no way out of it, and he loved his tea. And he was really clear he wanted his tea unthickened. And so the day before my dad died of an infection, we don't know if it was lung or urine, but the day before he died, I was able to speak for him and say, don't make him nothing by mouth, give him his tea. And so he went out on his own terms at 86. Would I have liked to have had Dad around longer? Yes, I would have. But I was ultimately very comfortable that I was able to express Dad's wishes and let him go out on his own terms. It felt to me like it was the most respectful thing I could do for him. So, being a surrogate can be difficult, but it's deeply important to honor the person and to help them in this way. And so one thing I want to make clear is that you can't anticipate every situation. I've seen some documents where people say things like, if I have a 10% chance of this or 40% chance of that, and maybe that'll work out, but there's really, and I'll put this up here just to point you towards 2 things that I see being really the basis of a lot of decisions. And one is this attitude towards medical treatments, invasive medical treatments. So an invasive medical treatment is, being on a ventilator, especially for a long time, or a PEG. Now, not everybody's heard the term PEG, but it is widely used. And so I'll just make sure that you're familiar with it. A PEG stands for percutaneous endoscopic gastrostomy tube. That's the tube, you probably can't see me pointing to my belly, but that's the tube that we put in the belly for someone to get fed and fluid. But that's an invasive thing because we're making a hole in your side and putting this tube in you. And some people are fine with that if that helps them, and other people do not want invasive medical treatments and have strong feelings. So it's good to know what your loved ones want. The other big sort of broad topic are people's values regarding preserving their life. You had my dad's example. He'd made peace. He knew where things were going, and he didn't want to continue his life knowing that he was going to get weaker and weaker and more dependent. He was comfortable. He was happy where he was, if one can say that. But you have other people, often with religious beliefs about it, who would be completely horrified by that choice and believe that everything should be done to preserve life, including being on a ventilator for a long time, many admissions to a hospital. And so try to understand how someone feels about preserving life. You know, is to them all life sacred no matter what? Or is it a different point of view? And I think when you can understand that, you're well prepared for whatever situations come up. So now I'm just going to talk a little bit, since we're on the topic of end of life, just a few other little tidbits for you that I've noticed that people might want to be aware of. And so one is specific privacy concerns. If you're going to serve as the proxy, the surrogate for someone, just double check. Do they have something that they don't want someone to know? So for example, does mom have a brother Bob and she doesn't want Uncle Bob to know that she had a mastectomy 20 years ago? Yeah, I don't know. I don't know why that might be a secret, but it might be a secret that mom has, and it might be important to mom. So just check, are there specific people or specific things you should be absolutely aware of that they wouldn't want shared with somebody else? And of course, you're going to respect their privacy concerns anyway, just ethically, but you never know. There may be a secret or something that matters to your loved one that you might be able to ferret out and then be able to honor them by keeping them private. We'll touch on hospice. My upcoming slide and my last slide is on hospice. I also want to mention phone banking and computer access. So in this day and age where so much of what we do is online, whether it's our, equivalent of our, our personal phone book and list of our friends, it's on our phone and our computer, whether it's banking passwords to pay the bills. These are all passwords that I've seen difficulty happen when something happens to a spouse, whether they die or they are just incapacitated, like they're in an accident and have a head injury, and they're not able to communicate these passwords. The spouse can really have a lot of struggles or the children can have a lot of struggles trying to make sure the bills are paid, the right people are notified, all of those things. I suggest when you can that you share them with a loved one, but if you aren't comfortable, and not everybody shares everything with their spouse or their children, another way to do this is you write down the passwords on a paper, put it in a sealed envelope, and then put it someplace secure with instructions not to be opened except in the event of incapacitation. And that way the person can access what they need to access to keep life going. Okay, a few other just little things that if you're having these conversations, you might want to touch on. Things like final arrangements. Julia said that, the document doesn't cover that, but, do they want to be cremated? Are they in horror of that idea? Do they want to be buried? Is there a family plot that maybe you didn't know about? No, it's worth talking about. They may have specific wishes for their services. They may want donations to a particular cause, or have some concerns about their pet, or even have specific things that they want put in their obituary. Okay, and now our last slide. So palliative care and hospice. These are important things for people to understand, and they are very misunderstood, both within the lay community and the medical community. Palliative care is not the same thing as hospice, and hospice is not the same thing as palliative care, despite the fact that they're used interchangeably. And people often don't know about it, and they miss out. People that might have been very well served by hospice services miss out because they either don't use it at all or they use the hospice services too late. And I'll also tell you, as a physician, many times physicians do not bring this up, or they bring it up very, very late in the course. And they don't bring it up partly because they don't understand it in some cases, and partly because they've had bad reactions by families that they then are, honestly, as human beings, kind of afraid of. Sometimes when it's brought up, the family thinks that the doctor is saying, well, you have to give up on mom. And sometimes when it's brought up, the family thinks, oh, this doctor's no longer interested in taking care of mom. And doctors want to have a nice relationship with people. And so sometimes they don't bring it up even when it might be appropriate. So I wanted you to have the information so that if it ever applies to someone in your life, you know. Okay, so let's talk. What's palliative care? Palliative care is the broad term describing an approach to care that focuses on symptom relief. Symptom relief regardless of the stage of illness. So you can have palliative care early in the course of an illness. It's just about the physical, emotional, and spiritual comfort. Hospice is a type of palliative care, but hospice is specific to the last 6 months of life. When you're in hospice, it is thought that you have 6 months or less remaining of your life, that you're in some way terminal. And then what it does is it starts to shift the focus from cure to quality, cure to comfort. Now, there are some myths out there about hospice. Some people think hospice is only for people with cancer. Absolutely not. You can have any diagnosis as long as a physician or nurse practitioner thinks that you are within the last 6 months of your life. Now, guess what? We don't always know. And because it is often so hard for us to say, the question that gets asked to help physicians decide about this, the question is, would you be surprised if this person passed away within within 6 months? And if the doctor or the NP says, no, I wouldn't be surprised if they passed away within 6 months, that's actually considered predictive. And that it's been a validated question. So that is actually what we often use. And so what they do, they write an order for hospice. And what happens if the person doesn't die? You're on hospice, but you don't die. Well, if we still think that you might die within, or you're likely to die within 6 months, hospice can be continued. And sometimes people that we think are going to die rally and get better, in which case hospice can be stopped. It's not a you must die or we're going to make sure you die kind of service, not at all. It's just a service that comes in when we think that your passing is going to be within 6 months. So let's see. The other myth is that you don't have to be actively dying. And a lot of times that's when hospice gets brought in. I see it in the hospital all the time where it is very clear this person is not going to survive much longer and they call in hospice. And then hospice is only in for a couple of days. When if hospice is in for a longer time, there is so much more that can be done. And by the way, with hospice, you don't have to stop all treatments. You can have many treatments that are aimed at helping improve your quality of life. And the great thing is that insurance covers hospice. It's a Medicare benefit, and many private insurances cover hospice. And you can get nurse visits. There's a lot of work done to support family. There's counseling for the person who's ill, and drugs, equipment, supplies, for continence and other things. All those supplies, they're covered in a hospice benefit, as is PT, OT, or speech, which may help the person be able to move or be more comfortable during their last phase of their life. And some hospice benefits include art and music therapy. It can be a wonderful way to allow a person to come to peace with the fact that their life is ending and allow the family to accept it and come to peace as well. And some of the nicest, most warm people that I've ever met in my life work in hospice. And the last thing I'll say about this is sometimes people have in their minds that hospice is a location. And there are some freestanding hospices. And there are some nursing homes or hospitals that have hospice programs. But the vast majority of hospice is done at home. Most hospice care is done with the person because most people at home. Most people want to spend the end of their life at home with their loved ones, their family, and their friends. So just something for you to be aware of. So as this comes up, in case somebody doesn't approach you, this may be something to ask about. Okay, so that is the end of our talks. And we thank you so much for attending. And now I'll turn it back over to Julia, who will lead our question and answer session.
Okay, thank you.